Hi, sweetie.
Hi.
Any idea what we're going to talk about in 4 minutes?
I have, well, I think some people already joined, maybe. Some people are, I
Did you
think like 9
you see what John Sharkey posted this morning?
Yes, I did. And it was actually yesterday. So I texted him privately and I was like, thank you. I took a screenshot and I showed my husband and he's like, what's this? I'm like, imagine if Wayne Gretzky
Uh-huh.
said, a friend,
Uh-oh. Is that me?
Yeah.
Imagine Wayne Gretzky said what?
I said, imagine if Wayne Gretzky was on Facebook, said, you need to listen to this coach. He's a great guy. He's like,
Yeah.
oh, he's like, John Sharkey is like your Wayne Gretzky. I'm like, well, he's one of them.
Yeah, absolutely.
So
isn't that cool?
So
Thank
cool.
you.
I love our little community.
I do. Absolutely. I got the
if you want to click on the chat and then the Q&A, you can put those, I think you can put the windows off to the side.
Chat, let's put these guys
We have
here.
chat already.
Oh, they're already here. Hi, Marty.
Oh, yeah.
There you go.
And then if you click on the Q&A, I'm not sure, because that's another one. Okay, you can just
No
slide that over.
questions. Slide that over here. Slide that over there. There we go. There we go. My glasses off. No, then I can't see you. So we're going to leave the glasses on.
Keep them on.
Now reflecting. So
we had some good fun feedback about this podcast that we started.
Impromptu as it was.
That's just, I think that was my favorite part of the feedback was I love how just natural and organic and not preachy it was. And I was like, well, that's just what happens when you and I talk about stuff.
That's how we roll.
I got some really cool questions that came in and some comments already.
Okay.
But we can save that for
another time. Started last time.
Okay, yes.
So, but that works.
Okay, so I wrote down 4 of my favorite questions and comments that we got, but one that I wanted to ask you, and it's kind of a generic question, but I mean, I think we can roll with this one for a little bit, is what was the best piece of advice you've received?
Advice I have received?
Yeah.
From, well, it's not advice so much as mentorship.
Right.
If you have listened since 1995 to Jeff Bland,
yeah,
the best advice he gave anybody was think about, I'm putting my phone on airplane mode, the best advice, and he never gave advice. He just demonstrated it.
Mm-hmm.
Where does it come from? How does it work? What's the pathway? Yeah. They have leaky gut. So that's the end product.
Mm-hmm.
How did it get there? You can't just fix leaky gut. You have to fix how and why they got it. So probiotics, diet restriction, blah, blah, blah. That's the people that really know what they're doing don't give advice. That's what have you found that?
I found that the best people out there, the people that I want to Velcro myself to, are always so inclined to help and teach. I found that with Dr. Mark Lindsay in the late 90s when we were learning ART. And some of the really good clinicians wanted to just take some of the skills and morph it and do their own and not share. And the best of the best have been like, yeah, you can do it like this, but come here, I'm going to show you something really neat. And what do you think? And they've been, like you said, they're prompting your own critical thinking and sharing for the greater good.
Well, and without saying it, the message is my job is to make your job easier.
Yes.
Right?
Yes.
So Leon Chatel, those that know what they're doing do what they do so well. What did he have? 85 books. And then they encourage others to do their best.
Yes.
So because of Leon, I am now the write this case report up as a paper and publish it, NAG. Because unless somebody tells you, you should publish this. Well, it's
Right.
just a case. No. There, once it's published, then it happened. And somebody can learn from it. So that was Leon, Jeff Bland. And then the other night, those nights where you wake up at 2 o'clock in the morning and there's this thing in your head that you have to get out of your head and onto paper.
Yes.
I wrote a thank you note to my GP that I've had since 1986. And he moved to another clinic that's too far away about 5 or 6 years ago. So I don't see him anymore. But when I got to thinking about how I learned how to practice, he doesn't do physical medicine. But my son came in with contact dermatitis. It was absolutely the outline of his t-shirt. So it looked like contact dermatitis from a new soap.
Mhm.
And John did this. He went, pressed on his belly on the right, pressed on his belly on the left, ordered a mono spot test. And the kid had raging, dangerous mononucleosis.
Wow.
And I said, what made you keep going? He didn't look right.
Wow.
So just by doing what he does so well, what I learned from that is be observant, follow your intuition, and don't stop until it makes sense.
Whoa, can we put that on like a slide right there?
Okay, I'm writing it down. What did I just say?
Be observant. But the last part is don't stop until it makes sense.
Yep.
And I think when people hit stumbling blocks, when I look on our FSM practitioners page on Facebook, and when I get questions after the courses and stuff, the questions are great because they teach me where I failed to communicate something properly.
I thought I said that, but apparently I didn't say it in a way you could hear, right?
Correct. Yes. So, I've got 2 angles I want to attack right now. Okay, I'll just go on the first one, then remind me to come back.
All right.
Okay. So when we get these questions, yes, the first part is, okay, I failed to communicate that properly. And the second part is, again, going on that riff of don't stop. And I think because we get this awesome rainbow of practitioners that take our courses, we don't just get trainers or PTs or chiros. We're getting veterinarians and pharmacists and acupuncturists and optometrists. Yeah.
Okay.
Like you name it. And then just lay people that want to learn more about what we do, but I think that's the problem, is when you have a scope of practice, yes, you have to stay in your lane clinically, but you have to extend into those back corners of your brain and think laterally about, okay, well, I have this, and this, and my scope in physical medicine I can't go into the gut. I can't go into autoimmune disease, but have somebody that can for you, because you're right. Like, it will only take you so far. Your results will only get so far. And then if you're not getting that underlying cause, like, well, you're just never going to close those cases.
I have to raise my hand.
Do it.
And that is part of what you said isn't true.
Okay.
Your scope of practice is physical medicine, right?
Yeah.
Okay. And somebody has inflammation in a facet joint or something in their neck.
Yes.
Right?
Yes.
Is the vagus nerve a physical structure? Sorry, but
yeah.
It's right. There's no way to treat a physical medicine problem if the vagus nerve has been turned off by infection, stress, or trauma.
Correct.
Now, you can't treat infection because you can't prescribe antibiotics or the things it takes to fix mold,
Right.
but you can turn down the limbic system.
Mhm.
There are frequencies that do that. And by the way, I'm rewriting the Vegas presentation to make it into a webinar for Friday. And I
Yeah.
can't believe how bad it's been the last 3 times I taught it, because now I completely rearranged it. Sorry. Anyway, so there's going to be a webinar Friday about the vagus nerve,
Yeah.
but it's a physical structure
Yes.
that regulates everything, including inflammation.
Yes.
So yes, you can.
Yes, you can. Yes.
Yes,
And yes, you can. So that's the other slide. Yes, you can.
yes, you can.
And I remember taking my first in-person course in Austin,
Ooh,
2000 and
6,
yeah, I think
long time
2000.
ago.
And by the third day, we're going through like GI stuff. And I remember my brain wanting to just be like, you could just leave and get on a flight because you don't deal with organs.
Yeah.
And wanting to dismiss that all. And then I sat through it like a good student that I was. And then being on the plane, making a list of all the people that I had to call because it wasn't their psoas. And why would I have treated anything but the psoas? That's all I knew how to treat in the abdomen. And I've done some courses in visceral manipulation, but it's different than re-feeling it.
It's why we teach it, that talk about learning how you didn't communicate it properly, or how I didn't communicate it properly.
Yeah.
I'd never put the psoas, the ovary, the heart, the kidney. I never put that in the physical medicine section until 4 or 5 years ago, because
Was it after we treated a certain Olympic swimmer?
something like it was, yes, after it kept smacking me in the face and saying, okay.
It's not a psoas.
Yeah, it's never the psoas. It's
And
never.
I remember that moment where you just stopped because it wasn't doing anything. And it was like this moment where, did you ever slip and fall on the pool deck? And he's like, oh yeah, I did. I'm like, why would she be asking about that? Oh, well, what would happen if he slipped, fell, and landed flat on his back?
And his kidney got bruised, and
Yeah.
it glued it to the QLs. And so the QLs stopped firing.
Yeah.
He actually tore his QLs
Yeah.
by exercising a muscle that was inhibited.
Right.
It's like, so there's no way to treat physical medicine without having some idea of how it's connected to visceral medicine. It's now that's why the physical medicine section is longer. And those terrifying slides that, I mean, aren't they terrifying? The one
Now
with
they are.
it's like, no, don't tell me about the large bowel.
It is. It's those gnarly netter pictures, right? Where you're just like, no, I don't want to go back there. Oh, yes, you have to join us. Come on, come.
But then the story about the rotund rheumatologist who had all the trigger points in his left QL, in his left obliques.
Right.
And it's like, have you been in an auto accident where no auto accidents? Have you started an exercise program and done 200 crunches in the last week? And he looked at me and said, do I look like I have ever done a crunch? Okay, so it's not the muscle. If it's not the muscle, what is it?
Right.
And that's where you go back to look for the cause, right? So this GP, I'm gonna let you take your other tangent, but I got to do this other thing that this GP did.
Please.
Because he's why I'm still here. After my open heart surgery, they said, go see your GP in 2 weeks. And he said, why are you here? And I said, no, they told me to come in 2 weeks. It's 2 weeks, so I'm here. And he said, oh, okay. How you feeling? Fine. Good. Wow. How'd you do that? Blah, blah, blah. And he gets up and heads to the door, and his hand is on the doorknob. And I said, Well, there is one thing. It's hard to get it. It's been ever since Monday. This is Friday. Ever since Monday, it's hard to get a deep breath. And he absolutely stopped cold with his hand on the doorknob. Who do you know that would do that? Yeah. So
No, yeah.
that's the place where I learned to listen and take the time that it takes to get it right.
Yeah.
And that's why I teach what I teach. It's like, you got to listen.
Yeah.
And when it doesn't make sense, it's like, why would she? Let me take a chest x-ray. Let's do a white count. Oh, and my left lung was 2/3 full of fluid, and I had left lower lobe pneumonia.
Wow.
And if it wasn't for him, I wouldn't be here, as far as I'm concerned.
Yeah.
So, okay, now your other track.
Well, mine was just to circle back to that question, the best piece of advice. I'm going to say, and I've said this multiple times now, it's what you said to me the very first time I spoke at the advanced. And I think about it at least 5 or 6 times every single day.
Okay, that's scary.
So that's how profound it is.
Okay.
And it's what you want to say is not what they need to hear.
What you want to say is not what they need to hear in order to learn what you want to teach them.
Yes, I've shortened it a little bit for my little brain.
Yes, but no, that's the shorter version is probably more correct.
But it works with listening to patients and, fighting my manual therapy skills of press harder. Don't need to press harder.
Yeah.
It's really listening to what they're telling you so that you know where to start properly, and to not be preachy or in their face. Like you what did my dad always say? You have 2 ears and 1 mouth for a reason.
I love your dad.
Yeah.
Yeah.
So I do try to listen more, speak less. So, I mean, it's very helpful, obviously, with teaching. And when we're presenting and we're teaching, I have that in my head about what concept do they need to keep here, all the time, so that it doesn't just go right through. Something has to stick. And I do it when I'm talking to my kids and when I'm training my puppy right now. Like, I want to do certain things and I have to fight against it because what do they need? And I think with patients right now, I know I'm in this point of playing with FSM, that I think you have those days where you just really feel how profound it is what we have and the changes that happen. And I think I really learned that. And I spoke about that patient. She was in the symposium. She had a very, very bad car accident. So there's just a ton of trauma. And you want to get so excited as a practitioner because you have all these tools and you're going to change, and you have to take it in steps. And I always think about what Dr. Billick has said about you have to give them some good before you can take out the bad. So supporting the patient.
Put in the good stuff.
Yeah.
And the thing I've learned, I'd say in the last 2 years, because since my practice is so small, I have this luxury of having 1 or 2 patients in an afternoon, sometimes only 1. And when you have 2 hours with somebody, you make these huge changes. And what I've learned is they need time to get used to who they are now.
Yeah.
Now it's like I give myself Wednesday off to work in the office, but and you have to warn them. It's like, okay, the patient gets up and says, this feels weird. It's like, yeah. Have you ever downloaded a new operating system onto your computer? That's what your brain is doing right now.
Right.
Your leg only used to be pain. And now we took away the pain. We quieted down the spinal cord. We quieted down the central sensitization. We reconnected it to the sensory cortex. Then we drove it back down from the sensory cortex to the cerebellum to the spinal cord to the leg. And the patient at that point, you know, glazes over. It's like, did you do that? It's like, yeah, we did that. Now your body's your brain is actually trying to figure out what to do with the changes we just made.
Right.
Are they going to be permanent? I don't know. How long is a piece of string? It's like, maybe, and we'll treat something different tomorrow. But the being patient part and letting them know what's coming. So what's that other thing? Tell them what you're going to say, then say it, and then tell them again.
Yeah.
Marty says quiet down is 124. No, quieting down is 40.
Yeah.
So to quiet down, central sensitization is 40 and 10, or spinal cord sensitization is 40 and 10. Quiet down nerve pain is 40 and 396.
Right.
Central sensitization, what happens in the limbic system that makes it mind the pain so much? It's the limbic system, the insula, actually. I just wrote an article for Townsend Letter. So it's the insula, not the thalamus, but it's part of what we have as the midbrain that amplifies pain, gets used to it. So it feels weird to be out of pain. So the brain will recreate it, whether it's there or not peripherally.
Right,
Because
right.
the brain has a place that says this thing hurts. So that's what 40 and 89 is for. And I have had patients with really chronic pain. This is why I treat with 5 machines on one person. I have one that's just running 40 and 10 the whole time, and another machine that's just running 40 and 89 the whole time.
Right.
So take out the spinal sensitization, the central sensitization, then you get rid of the pain, and the patient says, it's like I can't feel it. That's when you turn off 40 and 89, you turn off 40 and 10. I can't feel it. What does that mean? That means the sensory cortex isn't connected to your leg, because the only place your leg has been is up in the insula, up in the thalamus.
Right.
So at that point, you do 81 and 92 to increase secretions in the sensory cortex from the brain down to the foot. And then pretty soon the patient says, oh, it's not numb anymore. Okay, fine. Is it hypersensitive? Nope. Nope. How does it feel to be out of pain? It's different, but it's okay. Okay, it's okay. And it's because we have the ability to manipulate the whole chain. So treating the sensory cortex is not part of your scope.
Right.
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 But not, it's also very much a part of your scope, because there's no way to get somebody's leg to work
Absolutely.
dealing with the brain and the nervous system. And we have a tool that lets us do that.
Right. No, it's true. I mean, I think we just haven't thought of it so microscopic before. You know, when I was in college, I touched on this last time. I wrote my thesis on pelvic instabilities, more specifically internal rotation restrictions. And we had 3 groups, one that just received manual therapy, one group that just got exercise rehabilitation, and one group that got both. So no surprise here, the group that got both manual therapy and exercise prescription got better, blah, 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 blah. But then you have to break down, well, why did that happen? And some of the
in the discussion, right?
But it's not just as easy as, oh, it's because they got stronger or it's because they maintained length. A huge part of it was retraining balance, the joint kinesthetic receptors. And so, yeah, maybe, 24 years ago, I wasn't thinking about the sensory cortex and the cerebellum and any of that, because I was just thinking about balance and coordination. I was thinking of the last part of that whole arc.
And all of that is true at
Doing
the same time.
Totally. So, any patient of mine that comes in, whether it's a professional athlete or, somebody who is sedentary, works in a library, they're getting some form of exercise prescription at the end, because you have to close that feedback loop. And even if it's them just standing on a balance pad for a couple seconds to reintegrate and asking those questions, how does that feel? I don't know. Like, just keep standing there. It feels good. I'm like, keep standing there. I like my hip. And now we're done.
There we go. Yeah.
You know, and it's funny. I found that it doesn't matter how long a patient has had that injury. I think the longer they've had it, the longer you have to convince them that it's okay to not be in pain anymore.
Well, and the toe heel walking
Yeah.
thing, that's magic. One of our practitioners taught me that 18 years ago.
Yeah.
And it uses all the same muscles that you do in regular walking, but it gets the information about the state of those muscles by a pathway that the brain doesn't expect.
Right.
And so the brain says, wait, what? The hamstring is what? How long is it? How do I wait? And so they get really wobbly, and that's the be observant part. They're really wobbly the first 25 feet that they do toe heel walking.
Mm-hmm.
And then they do another 25 feet and they're less wobbly.
Yeah.
And you can see it when it smooths out, then the brain is now connected to those muscles in their current state.
Right.
Then you have them turn around and walk normally, and the limp is gone and the hip drop is gone and everything's okay, fine.
I use that even without a asymmetrical gait pattern. So if I have, and it's in the sports course, I have it on video with a professional hockey player who had some like misfiring with his hip, nothing that anybody would see if you were a regular person, but if you're getting paid a lot of money to put pucks in a net, it's that last 1 degree. So it was the first thing we did. I'm like, I have to get this on video. So I'm following him on the track, and everybody I show it to, like, he's a professional athlete. Dude can't even walk down a track straight. I'm just like, you have no idea how hard this is after I've taken apart something and you're putting it back together. But it's that. And I think especially if you've had it for a while, or you're a professional athlete that's been training a pattern over and over and over again, the minute that person gets up off the table, they're going to go back to that default position because that's all they've known how to function. That's their survival mode, right? That's what's gotten them to work day after day. So putting them in a inorganic pattern right off the bat is, I think it's huge.
Has to be done, because when you think about how it was he was functioning in the state he was in, dude can't even walk down a track. And you look at what's torn and broken and you fix that. Okay, there's tendinopathies there, and so that muscle's turned off and that nerve is glued to that, and you had a kidney infection or a kidney stone, so your psoas is this long and that psoas is the other. And this, all the cerebellum knows is that this guy's getting paid a lot of money to do this activity, and I'll do whatever I have to do to get the puck in the net.
Right.
When you fix the dysfunction, your approach to getting them all better, doing the frequencies is not just the thing. So the worst stories I hear are the patients who tell me the practitioners put them in a room, and how's the puppy? The practitioner puts them in a room with wet towels and then leaves them alone, never touches them.
Right.
It's like, no. So you have to feel what's going on, be involved in the process. You don't have to stay in the room if it's something easy like a disc. But when you get the nerves unadhered from the old groin injury and all of a sudden his glute starts firing, and then when you fix the adhesion from the hernia repair that was gluing the cutaneous nerve to the skin, so that inhibited those muscles, when you take away all those adhesions and you fix the tendinopathies, the mechanics are completely different.
Yeah.
Yeah.
Yeah. 100%. Totally. When you have a patient, let's just go off of musculoskeletal pain. If you have somebody who's got, I don't know, pick one of your favorite autoimmune conditions, or like Lyme, or somebody that comes in with, let's say, not a palpable restriction.
Right.
How then are we going to close that loop? Because we're not dealing with balance. We're not dealing with, so enlighten us.
Thanks. No, that's where you have a team of people that you trust.
Yeah.
So there's a naturopath here, and I send my Lyme patients to her.
Yeah.
So I can't fix Lyme.
Yeah.
A patient that comes in with one Lyme band and not 5 Lyme bands in my, and she has all these symptoms in my world, she doesn't have Lyme.
Right.
She has the downstream effects of having had Lyme.
Right.
And 3 people have told her she feels crappy for the last 13 years because she's had Lyme, even though she didn't have a tick bite or a rash.
Right.
Does that make sense to you?
Not to me, but
That's the other thing. It's like, it has to make sense.
right.
So, but you can't disagree with the patient because they firmly believe the 3 people that told them that they feel crappy because they have Lyme.
Right.
And then I do a vestibular screen. And one of the members of my team is of a FCOVD optometrist. And she said, oh, I feel nausea and I have all these symptoms, and the fatigue and the anxiety and the depression and all that stuff. And oh yeah, I had an auto accident, but I got better from that. Which way was your head turned? I don't know. Well, think about the accident. Which way was your head turned? Well, it was turned to the left, and you got hit side impact, right? Yeah. Did the airbag go off? Oh yeah, hit me right in the side of the head, but I can hear fine. I know what do you, okay, fine. So you do a vestibular screen, she gets prism glasses, and 80% of the symptoms that she ascribed to Lyme aren't Lyme.
Right.
No offense to the Lyme committed doctors, but unless you've ruled out the other things that cause disequilibrium, nausea, fatigue, anxiety, that whole host of diffuse symptoms,
Right.
it's, yeah.
And that goes back to your point of never stop looking, until it makes sense.
Yeah.
And then you can maybe stop.
Well, and it can always be something that you didn't think it was. That's another poster, isn't it? It can always be something that you didn't think it was. So just because I have a hammer doesn't mean that everything's a nail. FSM doesn't fix everything.
No, and I think you do a great job of teaching that. Don't get too attached to your hypothesis, right?
Yeah.
I hate being wrong. I will, that's one of the things I don't do well with that, but this has taught me humility. I will,
Times are wrong.
Oh yeah, and at the same time, I also hate when I'm right, because once you get a little savvy with it and something more serious is going on, it's almost those times where you're sending people, I think you might need to get some imaging of your spine or some imaging of this because there's something else going on, or this doesn't feel right. And I can't tell you how many times I've been right because it never not works. And if what I'm doing doesn't work, there's something else going on.
Did I tell you already about internal shingles? Was that last week?
You did last week.
Swear to God. I treated him. I talked about it Wednesday.
Yes.
I treated him Thursday or Friday as internal shingles. Now, I went down the rabbit hole. First, I had to make sure it was not pancreatic cancer, liver mets, any of the serious stuff. All of that imaging was negative.
Okay.
And then the PT
So
that
remind the folks who are just turning in today, who maybe didn't hear that first podcast, maybe what that patient presented with.
the patient had abdominal pain that was just really sharp and burning and really painful. It was the right upper quadrant, like just below the ribs, but at first he was describing it as all the way across.
Okay.
And he'd lost 25 pounds in 8 months. That I didn't like that part.
Yeah.
So I sent him out, I treated him, he got some better, sent him out for imaging. And we found out it's not pancreatic cancer, it's not his gallbladder, his liver's fine, his blood works fine, he makes amylase and lipase. We found out all the bad things it isn't. And I didn't do a sensory exam because I just ran my hands over his skin, it was fine.
Okay.
The next week, I'm treating him. Now we've decided that it's some sort of nerve thing. Okay. The PT who works on him at her office and I are on the phone, and she said, you know, there's a thing called internal shingles. What? Internal shingles? They never get blisters. It stays internal. They never get blisters. So this time I did a proper sensory exam with a pinwheel.
Yeah.
Nobody in the emergency room did it. He's been to the ER 3 times, been to urgent care 2 times, and he's seen me twice.
Wow.
And right. So we did a sensory exam, and there it was, T6 to T9. And Jody looks it up and says, internal shingles is a thing. It is not. And then I Googled it on my phone. It is, it's a thing. They don't get blisters, it's internal.
Jeez.
But it manifests in a dermatomal pattern that would make anybody, and so that's where they don't stop until you figure it out. So I treated him for nerve pain before. This time, he hasn't slept in 3 months.
Okay.
Because of the pain. Pain is worse at night.
Yeah.
Pain that's worse at night is always central. So I did 40 and 10 with one machine, 40 and 89 with another machine. Did the
Just have it neck to feet.
Neck to feet.
Yeah.
And then from the spine to the abdomen, I had 3 machines. One ran the shingles protocol, right? The 3 frequencies for shingles.
Yeah.
One ran once, and that one, when those were done, I ran 160 malignant virus in the nerve. So I treated the virus with one machine, 40 and 396. But then the other one was 81 and 396. The problem with post-herpetic neuralgia is the nerve is destroyed. What he had was the equivalent of phantom limb pain from T6 to T9.
Wow.
Yeah. So reducing inflammation in the nerve wasn't going to get it. And I knew that from all the times you fail, thank goodness.
Right. Yeah.
And then I did 81 and 396. And it took an hour with 5 machines on him. And then he said, it hurts when I move. What's that? Scarring in the nerve.
Yeah.
When you move and it hurts, it's never the muscle.
Yeah.
Not when you have that. So I did 13 and 396. And he said, oh, that feels good. So I got into his belly and moved all those nerve roots and mobilized his chest.
Yeah.
Had him take a deep breath, had him cough.
Yeah.
Right? And it was still sore. Oh, and that's when he said it feels numb. And that's when I turned off 40 and 89, turned off 40 and 10, and did 81 and 92.
Yeah.
And then the numbness went away.
Did you have him move with 81 and 92? Yeah,
Yeah.
just a bit.
And then 81 and 84. It was, and he's still, it's not finished. There are, have you found this with male humans? If it's not 100% gone, it's never, it hasn't changed.
Yeah.
Is that a thing?
It's definitely a thing, and it doesn't matter if they're professional athletes or not. And I have some women, especially athletes, that are like that. And you have to say, well, and that's why taking the pain score before treatment and before and after with range of motion is so important, because then you can say, do you remember when you came in and you could only do this and your pain was an 8? Oh yeah. Where are you again right now? Oh yeah, I can do this. And your pain? It's a 2. Okay. So trying to leave on that like cognitive note that there was progress, but you're right. You never want people leaving. They feel like they haven't done anything, right? Or nothing's really changed. So.
Well, and it says once again, data.
Yes.
What's your pain score? Right.
Yeah.
Oh, well, then they're scared to say it's a 3, because what if it comes back? Well,
right.
Comes back, we got it to a 3 this time. That means we might be able to do it again.
Right.
Yeah.
I had a teenager who was dying to return to sport following a procedure, who was lying through her teeth about pain because she knew if she had pain, mom wouldn't let her play, PT wouldn't let her play, or PT would modify the exercises because
it was dangerous.
It was dangerous and pain. So we had to have this like come to Jesus talk that pain is a good thing. It tells us where our healing's at. And in order for healing to progress in the right direction, we need to respect the pain. But it's really hard when you have an athlete, whether it's a teenager, a professional, or just certain people, they just pain score sometimes just, you have to have a backup. So like whether that's range of motion, right?
Yeah. And the Oswestry score, the neck and low back, the Tau scores, any of the functional measures are really helpful.
Yeah.
Yeah. Data is a good thing.
You need it. But then, going back to any of those systemic conditions, you can't do range of motion on the viscera.
Yeah. Well, and then there are people that like they've had SIBO for 40 years.
Yeah.
And we get them to no SIBO. Like they don't have SIBO anymore. And 3 weeks later, they have an episode.
Right.
Well, I still have SIBO. Well, yeah. Yeah. And what was your stress level like 5 days before you had this episode of SIBO?
Right.
Oh, yeah, I had to travel for work, and so what turned her vagus off that changed the pH in her gut that allowed the bad bacteria to come back? So it's dealing with patient expectations, especially after they've read about us on the internet. Oh my gracious.
Right. Because I think it's going to be a one and done.
Yeah. No.
I've actually should put a sign up and say, I am not the J&J shot.
Yeah, right. Yeah. Well, and the other thing that patients need to understand, and if you might have a way that you tell them, it's like you and I form a team. I am not going to do anything to you. I'll be able to correct some inflammation and scar tissue and imbalances and repair. I can do lots, but the stable state and how you progress, that's a team effort. How do you tell them that?
Yeah, really similar, and again, I have my other favorite quote of yours is, you can't want it more than the patient. Now with my athletes, that's never in question, because they will run through a brick wall if I say that will make them get on the ice or the field faster. But there are so many times where I have patients that I know, like, we've got profound changes on the horizon, but this is not my journey. Like you said, I'm just the facilitator, the hand holder, the background cheerleader, but they have to do the work. And I think, you know, similar to an athlete who spends, you know, 2 hours, I'll go to hockey for a minute, 2 hours on the ice. The great athletes are not the ones that just put all the emphasis on the 2 hours on the ice. It's what are they doing the other 22 hours? How are they eating, sleeping? So the stable state with athletes is really easy because they're quite pristine. Now they might have the psychological stress that happens with sport, but you're right. It's conveying to them, these exercises that you're doing, you might have to do them for the rest of your life in some sort of fashion to take care of your spine in order for you to keep being active, or shoulder exercises, and sometimes they look at me and they're mad. What do you mean I have to keep doing these stretches? I'm like, well, not these exact stretches. We'll keep modifying them, but you're going to have to keep moving. Well, I don't want to do that.
Oh, okay.
You might need to find somebody else to help you then.
Yeah, it's hard to bail out a boat while somebody's shooting holes in the bottom of it.
Right.
The same Olympic swimmer that we treated.
Yeah.
And we got the kidney thing sorted out. We got the psoas thing sorted out. Then we came back for the second session in the afternoon, and he had a bunch of trigger points in his rectus abdominis. And I said, why do you have trigger points in your rectus abdominis? So I treated the muscle. I ran inflammation and allergy in the small intestine, and said, what'd you have for lunch? He said, oh, there's this great sub shop down the road.
It was good.
Yeah. And
probably hear my dog in the background. Sorry.
So, and I said, you want to go to the Olympics in 2 years? Oh, I know. I asked him, it's like, has anybody ever told you you shouldn't eat gluten? Oh, yeah. My naturopath says I'm gluten intolerant, gluten sensitive. And I said, well, you want to go to the Olympics in 2 years? That's the last sub sandwich and that's the last gluten you have.
Yeah.
For 2 years, if you want to go to the Olympics.
Yeah.
And athletes will do that.
Yes.
So.
Yeah. Yeah. I think, well, I'm hopeful, like the patients, I think by the time they find us are at a level of desperation and open-mindedness. I think they come in both fashions. Either they've tried everything else and they're willing to throw reckless abandon to whatever you tell them.
Yes.
Or they're just a little bit more open-minded because they know what they've tried hasn't worked. Do you have a favorite, like steady state, stable state, set of frequencies that you like to give people with?
These days, concussion in vagus. There's absolutely no way you'll see. There's no way to get anybody better unless their vagus nerve is working.
So will you give them that like daily or few times a week?
They watch the news, right? So it used to be just run the concussion protocol, and then it's concussion in vagus. So did they drive in traffic? Have they been on the freeway today? Did somebody yell at them at practice or at work? Did they watch the news? Did they read the newspaper? Yeah, those are the things.
Yeah.
And infection, stress, and trauma. So it's the lives we lead are compared to what life was like 200 years ago. 200 years ago, we just had to worry about tigers, and if you broke your leg, you were dead, right? If you had a heart attack, you were dead. It was easy.
Yeah.
Now we recover from those things, but the lives we lead are, from a primitive physiologic standpoint, they're incredibly stressful. So I literally run concussion in Vegas on myself every single night.
Yeah.
Or, yeah, I am insulin resistant and I had pancreatitis for 5 years.
Right.
So I treat insulin and leptin and the pancreas. That's almost a 3-hour program.
Wow. Right.
178 minutes. So I run that. And then I wake up at 3 or so when it's finished. And then I run concussion in Vegas. So
Right.
it's like, it's the reason to make like a custom care and a magnetic converter a package, because yes, it's $4,000 or $4,500. Yes, it's that much money, but what's it going to save you
Right.
in terms of how much money you spend with me? I'd rather have you treating yourself at home. And right.
For sure. Yes. When it comes to those things, I think you would almost rather be in the comfort of your own home. I have profound feelings when I run concussion in Vegas. I want to experience all that in the comfort of my house. I don't want to be on a table talking to anybody.
No, exactly. Yeah, no, it's important.
I have another question for you that came in here.
Okay.
So I'll let you start with these. Do you always treat everybody on alternating current first as a default?
Older patients. So like if you're, I'm assuming they're talking about neck to feet stuff where you might run into stenosis. On older patients, yes. So if they're over, let's say 50, which isn't as old as you think it is once you're 75. So, so I'll run it alternating for like a minute or two. And, but in general, the spinal cord, the vagus, central sensitization, any nerve, they're all treated. I polarize them right away. The only one that ever gives people trouble is the spinal cord.
Mm-hmm.
Stenosis. And basically you watch their face. And if they start to squirm or make faces, it's like, what's going on? I got a headache. Really? Okay. So then you make it alternating, because the two things that will give them a headache are the polarized positive current, when it backs up enough that it increases the spinal fluid pressure in the brain. But the other thing that happens is that because they have, let's say, a disc bulge that's causing the whole thing,
Mm-hmm.
they tend to lay, and by habit, they put themselves into extension.
Right.
And so then you go up to the top head of the table, you put your fingers under the base of their skull, you tuck their chin, and you traction it just a bit. How's your headache? Oh, that's much better. So it's the C2-3 facet.
Yeah.
So C5-6 disc goes with the C2-3 facet. It's, have you ever found that it's not?
No.
Yeah. Okay, good. It's not just, it's like, it's always C2-3 facet and C5-6 disc.
Yeah. Yeah, I would agree. I mean, most of my athletes, and I probably ask you this every year, why athletes love being polarized. And I never, you give me the same. I don't know.
Even weekend warriors or people that are particularly muscular or work out a lot.
Yes, it doesn't, I don't know. And I've been asking you this since the very first course. And it's, I don't know, there's a lot. Every year someone's like, oh, I think I have an idea. And there's a lot of pretty cool, like, hypothesis that come out from there. But I had an athlete who I was treating and gave him a custom care. He purchased one after, and he called me within hours of taking it home. He's like, this one doesn't work that you gave me. I'm like, it works. I'm not stoned. It's not working. And this was a guy that would have to leave his keys at the front desk and we'd have to call him an Uber home after because he would get stoned. And I'm like, maybe it's just because you're doing it at home. Send me a video, make sure that the battery's plugged in. And he sent me a video. Everything was running. He's like, I'm not stoned. I'm fine. Look at my eyes. Look at my eyes. I'm fine. And then it dawned on me. I just threw everything on there alternating.
No, isn't that something?
I'm like, okay, I go, and I hate it when I'm wrong. I'm like, okay, just bring it back and I'll see what I can do. So I went in there, clicked everything to positive. I go, okay, go home tonight and try it again. He's like, okay. And then I never heard from him because he passed out and he was all googly after. So it works.
Love
And
it.
yeah, I don't know why, but it's
Speaking of athletes,
mhm.
I have a thing on my desktop, on my, file thing.
Yeah.
There was this file that literally I'd never looked at. It was endocrine, like, why would you read this, right? Endocrine implications of endocrine implications of traumatic brain injuries, TBIs, endocrine. Okay, fine, whatever. How good could this be? So last night I just opened it up because I didn't want to do what I was supposed to do. So I opened up this thing and it's 244 slides. It's an osteopath in Reno.
Okay.
And it mind-boggling things we
Crazy.
never check.
Oh.
Testosterone, growth hormone, progesterone, DHEA. What was the other ones? I mean, 245 slides. How could I? Anyway, the good news is that I emailed him. He answered me today. He will take my son as a patient, but the important thing is he's got 2 hours at the advanced in February.
Very cool.
That may annoy David Musnick, who's used to being the TBI guy, but
This is a whole other spin that I think is incredible.
strict, and it's amazing. I'm so excited. I can't even remember his name. Clearfield. He's in Reno. So we will, and he's going to ask me, why do you want me to talk to your group? Because we treat traumatic brain injury patients.
But we don't think about that side of the coin.
No, because not that many of us are MDs. There's about a quarter of our practitioners are medical physicians.
Yeah.
But
even for those of us that aren't, to be able to ask the right questions or to kind of go that way to refer for that, because
develop a
very helpful.
questionnaire.
Yeah.
And so isn't that exciting?
That is so exciting.
Yeah. Oh, and I have a new thing for the packet. And it is the, what do they call it? The Brain Injury Vision Symptom Survey. This is going to be part of the first time you take the core. Things you never thought of that would send people to an FCOVD optometrist.
Excellent. And that's going to be for all of us at the advanced.
Yep. It's at the advanced. I'm so excited.
Excellent.
Because, yeah. Okay, you were going to ask me something or say something.
No, I think we're almost.
Oh my gosh.
I know.
We did it again.
So we're so close on.
Do you have any more questions? You're getting the questions.
I know. I love getting these questions. So I do want to end on one just because I have it out here. So do you have a absolute favorite textbook?
Besides Netter. Yes.
This is what my answer was.
Yes.
So
besides Netter.
I haven't found even like, there's a lot of really cool software that I have on my laptop for patients that I can try to explain, but nothing gives me the visual and the comfort than going into my, and I don't even know what edition they're up to. This is Netter number 2. This is only the 2nd edition that I have.
We're up to 8.
Yeah. Well, they couldn't have changed that much, but I think anybody should have a Netters, and I don't care how good your anatomy is, because you learn anatomy differently with FSM. Yes, you care about origin, insertion, action, innervation, but it's the shape of the muscle that's different. It's what's its neighbors. What is it touching? What is it near to? And not even,
Where do the nerves go?
yes. So I want to just, so I was working with somebody's shoulder blade rib area. I'll just give you that information. And she comes in and my doctor says I have a rib out. I'm like, okay. When I hear that, it's like when someone says I have tight rhomboids. Okay.
Mm-hmm.
So for the tight rhomboid, she's like, yeah, my rhomboids feel tight. I'm like, okay, if you had tight rhomboids, you would be walking around like this. She's like, I would. I'm like, you have chronically elongated, scarred rhomboids because you are walking around like this. Everything that we do is in front of us. So
Just flex forward, the discs bulge, and that creates pain in between your shoulder blades where the rhomboids are.
yes,
But no, there's nothing wrong with there's never anything wrong with the rhomboids.
never, ever,
Ever. Okay, thank you.
never.
Thank you.
But people only know what they can touch and feel, so, and you, again, hey, this is the theme of this talk, is don't stop looking, because just because you feel something that appears to be on someone's rhomboid doesn't mean it's the rhomboid. So this is one of my favorite pictures that I show patients, again, through Netters, but so many people go, oh, those are my rhomboids, right? I'm like, no, that's serratus posterior. Like, that is super deep. And look what's underneath it. And this is your spine. And under that is the disc. And then there's a nerve. So no, you don't have a rib out. And I say it in my smiliest face. And then I run frequency for the disc. And they're like, oh, what you're doing on my rhomboid feels great. I'm like, it's not your rhomboid. So going back to my question about the book,
I don't, there's one other one that I use, but it's so esoteric and it's so rare that I need it, because Netter's the go-to.
Yeah.
There's that one. And then the 2 neurology textbooks, I can't even remember the authors, but I show the pictures of them, and they're for really weird esoteric stuff. And the other thing that happens with Netter is I pretend that I remember all this stuff, and I have a lot of Netters stuck in my brain.
Yeah.
But when you can't figure it out, I think it's okay to tell the patient, what is this? Let's look at it together. And you look at and this does that. It's like, okay, my favorite OBGYN when I was in my 20s was a doctor that kept the physician's desk reference back when it was a real book.
Yeah.
He kept it on a reading stand in every treatment room.
Wow.
Every single time he prescribed any drug, he looked it up.
Wow.
And it's like, okay, that's a good thing.
And you probably never once thought, geez, this guy isn't very smart. You probably thought, wow, he's being really thorough, and I really appreciate that.
Mm-hmm. I have to tell you one more thing about, okay, it won't take very long.
Okay.
This lady comes and she's had just incredible pelvic pain, like they flew from Colorado, and she'd had pelvic pain. Somebody decided she had endometriosis, so she had a laparoscopy, and that did one set of things. And then somebody told her that her endometriosis would go away if she had a hysterectomy. Okay, so they did that, and that made it worse. And then she had some sort of prolapse and so they put a mesh in. Okay. So I'm very gentle with the scar tissue and, you know, doing intravaginal work and this and that. But the way she described her pain was before she had a bowel movement, the pain was absolutely excruciating. Okay. Number one, I've never seen that before in my life or heard of that symptom. But as her rectum fills, the pain is excruciating. So you go back to Jeff Bland, go back to first principles. What happens when the stool comes down your descending colon through the sigmoid into the rectum, right? It's filling. You know how much that stuff weighs? Okay, so we're talking 4 or 5 pounds of poop. All right, what's it doing? Well, it's pulling on things. Okay. After all, oh my God. And what the physical therapists have done to her, that was, I mean, there was one dilator thing that they did that made everything worse. So then I opened up Netter and we looked at the pelvic floor. The pelvic floor muscles are these sheets and they're attached to the periosteum with 3 millimeters of connective tissue all the way around the brim. You know what fixed it? 124 and 77 for an hour.
For an hour. Did the pain change right away? Sometimes the pain changes right away with 124, but to fix the issue, it takes a bit longer.
Yeah, the pain started to go down, and then I had to treat the periosteum too. But then we had to take the scar tissue out of the rectum that was, right, all the surgeries and the trauma that she'd had in her pelvis. We had to take the scar tissue out of the rectum so it wouldn't pull on things. But the concept, never before in my life have I treated 124 and 77, torn and broken in the connective tissue for the pelvic floor.
But man, does that make so much sense.
When you look at Netter.
When you look at Netter. And then when you think anybody that's had a baby.
Oh yeah, there's that. Right. Yeah.
I mean, I've done a lot of good work with diastasis recti with 124 and 77 pelvic floor neighborhood, but not in that way. But wow, good for you.
It was like, oh,
fantastic.
Well, she comes here for a week, right?
Yeah.
To see Yoda. And it's like, it's Wednesday and Yoda is like looking for the back door. Right. So, but then it was like, it's those teachers we've had. It's Bland and the John Denker and the Leon Chato and the John Sharkey, and everything's connected to everything.
Yeah.
Although I'm really going to know John Sharkey because it's never the fascia. It's like, that's really going to annoy him.
I treat the fascia a lot. So, but
it's the fascia's innervated.
Yeah.
So you have to treat scar tissue in the nerve. Anyway.
Oh,
so
for sure.
124 and 77. It's like the pain started to go away right away. And then I just left one unit on her that ran 124 and 77 for an hour while I treated scarring in the rectum internally.
Yeah.
Right. So it was pretty fun.
Amazing.
It's 5 after 5 already.
It is. These hours go by so fast. So keep your questions coming, everybody. These are great. I don't know, do you have any announcements for the week other than you've got a webinar on Friday for the vagus nerve? That's on Facebook, I think, right? That'll be, or no, you're doing it through Zoom again?
Yeah, we'll do it through Zoom. It'll be an FSM
practitioner.
And it's different. I decided, because not everybody comes to the advanced. Now this year we're doing it live stream and in person at the advanced. So not everybody has seen this Vegas thing. And
Right.
it's, if I make it a webinar, it will always be on
Yes.
the website.
Yeah.
And people will be able to find it. So
And get caught up, and then they can hit the ground running at the advanced.
yeah. It's
Yay.
fun. What time? Oh,
The webinar on Friday.
what time's the webinar?
4 o'clock.
4
Sorry.
o'clock, Friday, Pacific time.
Yes.
For
our-
those of you in Australia, New Zealand, India, and Ireland, you'll have to figure it out. You can ask.
Perfect. And then I have another quick announcement. Someone's asking about the next live sports course. That's what I just saw. So I think it's going to be at the advanced in Phoenix, the next live one. I'm on the fence about doing another live stream before then, but I think we'll just, since it will be live streamed at the advanced and in person, we'll just go with that. And for all of you who have taken the FSM sports course, there's going to be an advanced FSM one-day course. So any of you who have taken the FSM sports course, the one day will be more intense, like biomechanical troubleshooting, some cool manual therapy skills, and a lot more proprioception, balance work, that neural repatterning stuff that I'm a bit of a geek with.
Does that mean I don't have that day off and I get to come sit and watch?
Yeah,
Oh, goody.
you can come play and balance and do all
Yeah.
the fun things.
I've got lots of things you can play with. That'll be fun.
We'll turn you into like a Cirque du Soleil person after. How about that?
Okay, that's optimistic, but great.
Hey, gotta aim high, aim for the stars.
Aim high. What a good time.
Questions, I don't know if you want to get them really quick. Oh, I think you answered them already. It was being recorded. You answered the quiet down is 1:24. You got that. And
40.
then you got the what time. We did everything. Awesome. So
Thanks.
if there are more questions, email us and you know where to find everybody.
If you
And-
registered for this webinar, you are automatically registered for the next 2 months. What webinar?
Perfect for this one. Our podcast.
4 o'clock,
That's a podcast.
the podcast, but it's a webinar on Zoom, sorry.
It's a webinar on Zoom, but it's a podcast.
Yes.
On it.
So
on
come
Apple.
join us. So come join us every Wednesday and get it like live as we're doing it, because that's so much fun. And then you can replay it and listen to it after.
I suspect we may graduate to champagne or fizzy water or something, right?
Ooh, that's a great idea.
You know,
And
it's-
eventually we'll have a theme and we'll have guests, but right now we have just way too much to talk about. So
yeah, there are guests that are coming. We're already working up a list.
I have such a great list. We'll talk about that in private though after.
Okay. Yeah. Bye, guys.
Bye, everybody.
Thanks. Thanks, Kim.
Bye.
Bye.
The Frequency Specific Microcurrent podcast has been produced by Frequency Specific Seminars for entertainment, educational, and information purposes only. The information and opinion provided in the podcast are not medical advice, do not create any type of doctor-patient relationship, and unless expressly stated, do not reflect the opinions of its affiliates, subsidiaries, or sponsors, or the hosts, or any of the podcast guests or affiliated professional organizations. No person should act or refrain from acting on the basis of the content provided in any podcast without first seeking appropriate medical advice and counseling. No information provided in any podcast should be used as a substitute for personalized medical advice and counseling. FSS expressly disclaims any and all liability relating to any actions taken or not taken based on or any contents of this podcast.